keeping this in mind. You have to think about cost, you have to think about space, you also have to think about the tertiary care corporates, which has the capability to have their own institution, their own IT wing, their own factory where they make things. That's how industry has changed. At the same time, when they have this capability, they may not want people to come in or your whatever. If you have some kind of a setup, linking you with the will be probably initially, then they'll get your ideas and they'll do it themselves. That's how the era is going to be. You have to be prepared for that. So anything you do, you should have something which is unique, which is not easily replicable. Am I clear? Otherwise, these big giants will be easy to do it easily. That's the reason I told you, because whatever secondary care which is going to survive may not may not have the capacity to buy things from you or get things from you. And the tertiary care is going to reserve it. So we are in the middle of a transition where it's going to be, you need to have financial and economical sense too if you are thinking about entrepreneurship. From a concept going to elsewhere, you should have a clarity. Text to sense. Go to the previous slide. So I'm just to give you an idea about the patient's journey map, interlinking with the doctor's journey map for you to understand. And then I don't have much of an idea about devices. Basically, if you ask me what happens inside a ventilator, I won't know. I will just know the modes. So if you need that, I can link you with somebody who's just obsessed with ventilators. We have some anesthetists and critical care people who are really into it. I can link them with you. I won't know. Probably you'll end up teaching me more than I can teach you. But the interface with the patient is where I come in. So, and then what about how is software and AI, big data going to help us? I didn't know you guys were also into big data. Otherwise, I would have put something, because we have started thinking about big data in a big way. No, though we have not achieved anything as such in the healthcare directly. Go to the next slide. Next slide. So when you talk about the patient, let's say somebody has a fever. So it used to be only three things initially. You go to a clinic nearby and see a doctor. That is a classical primary care. You go to an OPD in a small hospital or a big hospital. That's OPD in a secondary or tertiary care. But if you're very sick in the middle of the night, you go to the emergency. That's how traditionally it was. Now what has happened? We have three other fields which are coming in. It's useless. No problem. So we are talking about home care now. So if your grandmother has fever, she need not go. You can have a nurse coming home. She will see the patient. She will talk with the doctor and help you. Home health care is booming nowadays. So if you're talking about US and UK, home care came in because they had positive doctors. Here it is coming in because they're looking at innovations and ways to bring in new businesses. Despite being a lot of doctors here, they're still having, thank you, home care going in. Classical home care should be when a patient is sick, non-ambulant, and somebody supports them, but it's becoming more than that nowadays. Next comes telemedicine. You can sit in your office or a college, get an online consultation. That also is coming up in a big way. COVID paved way for that. We have portals where you can do that. And third one thing is, this is what we are fighting against. I have a patient coming to me, he will tell me about the diagnosis. Dr. Google is dangerous. He will give them all the common, uncommon things which I don't know. So I will have to constantly compete with the Google and ChatGPT. When they come to me, they will know all the answers. I will have to question them how you got the answers, and I'll have to question them about their symptoms. They will come with, I think I have appendicitis. I think I have flu. That's how people talk. You see, doctor, tell me the symptoms. No, you don't. If you don't tell me the symptoms, you can get treated with Google. That's what happens nowadays, because everybody comes with random Google. Now you have clear-cut health portals. You have sites where you get information. So what we have started doing, all of us have started writing things in our portals. If you enter into Kaveri's website, you will have information about, you'll have blogs about health. Go to Jason's website, you'll have blogs about health related posts, because now we are worried about misinformation. So rather than people tracing it outside, come to authentic sites, come to our own site. We will give you what you want. At least we know it will be authentic information. The problem is if you don't go to classical health portal, there will be a lot of misinformation because what happens when somebody writes an article, he will write it from other sources, may not be medical, and there will be a lot of side effects. Even for a single fever, for a simple fever for 1 week, or infection when the cancer very good. And the human mind is such that when you're sick, your mind catches upon what is most dangerous, most difficult to treat. And when you have a chronic problem, it will leave out the dangerous part, look into what is mild and doesn't have a process. Remember, acute is different, chronic is. If you're acutely sick, you think about the most dangerous stuff and then you panic. When you have a chronic problem, let's say you have diabetes, you have thyroid, which has been there for several times. Even when you look into the portal, you will leave out the things like MI, stroke, and all. Look into minor things. It will take 10 years to get an MI, it's only 6 years though. That's how human brain works. So both are dangerous for us. When you panic, it's dangerous. Apathy is dangerous. That's why, despite so much of information, obesity, diabetes is on the rise now, and we are not able to do anything. It's nothing to do with us, it is the way our brain is made. Next slide. Oh, sorry. So, once you have a problem, you have met somebody in the OPD or somewhere or seen in health portal, then you have to take up investigations. Traditionally, investigations will be you take an investigation outpatient, you go to the hospital, give it, or you go to the lab and give it, or in the clinic, they'll have a collection center. Or you get admitted, somebody will collect the investigations. If they don't have, they will outsource it, but it's done that way. And you will have master checkup. For example, if the patient requires a lot of investigation, patient comes from West Bengal, and you know you can't to keep on doing things, we send for a master checkup because everything is done at a single shot and it's less costly. Now, beyond that, investigations also have changed now. You have health camps, so I'm sure it must have happened. Your vans coming in your campus, doctors coming in, checking sugar, BP, eye examination, sometimes HbA1c. Those scans now, it's used to be just diet, just seeing a patient and regular screen. Now, investigations are creeped in there because of things like you're able to see the results on the place and people understand the value of a number. When I give you a number, it is better than saying that you're fine or not. Human brain again picks it up. If I tell you the sugar is 200, that gives an impact. Other thing, you might have diabetes, you go get it checked. Nobody will do that. So that was the evolution. This also helped the hospitals to get the patients in. So you have health camps involving investigations now. And then the new thing which has come is health kiosks. So Bangalore is innovation capital. You go to Bangalore, now you've got this health ATMs, health kiosks. Is it there in Chennai too? Not yet. So I guess one of them will have it. So here, like in a corporate setup, they will have one big some kind of an equipment like that. You go in there, you can check your BP, check your pulse rate, you check your heart rate, you can get your ECG done, you can check your sugars. So it's called a health kiosk or health ATM, where people will get those investigations done because otherwise those people go to the centers for that particular number because human beings like numbers. So rather than somebody saying you're fine or not, we prefer objectivity to subjectivity. So that's how this came in. Again, it has got a business potential. Third is home collection. Now you can sit at your place and call a lab person to come and collect you because in India, their numbers are huge. We need to give job to everybody. So we can have Swiggy deliver things at home. We can have home collection at home. We can have a nurse coming home to look at us. Everything at a cost. Next slide. So, if you're admitted in the hospital, the evolution. So, probably when I finished my MBBS, probably 25, 30 years back, it used to be patient gets admitted through emergency or OP. Emergency patient may stay for some time. You can have a recovery area. They go to the ward or ICU, OT recovery area. It used to be simple. Now, hospital has become more complicated. Now, you have daycare services. It is a hospital. Don't ask me how a daycare service come inside hospital. That's a concept which can happen only in corporate hospitals in India. Outside India, daycare services are different from hospitals. In India, daycare board will be inside the hospital. People come in the morning, take chemotherapy, go home in the evening. People come, get a surgery, go home in the evening. That's daycare services. This is something which has evolved in the last 10 years to cut costs. So if these outside can even cut costs further down, but obviously hospitals don't want that because they need the profit. Next comes certain special zones. Have you heard of isolation areas? After COVID, I think you should know. What is an isolation area? No, you've talked. Somebody else. Isolation zone. Isolation area. Come on, I hardly know anything. You guys know more than me in biomedical engineering. I'm a demented old lady. Talk out. Very good. So radiation isolation areas are isolated. Are they really isolated? Think and tell me, where did you have your CT mission in the? Have you visited a CT zone in the hospital? Is it isolated? Huh? Chemotherapy doesn't produce radiation much. It's radiotherapy which produces radiation. So what we don't actually isolate it. What we do is we put lead around it and keep it because space is money. Then we cannot afford to have separate areas. If you take up Europe, radiotherapy zones will be completely different. There will be separate hospitals for that. Daycare chemotherapy will be separate. That's how you see go to a Scandinavian country or Germany. That's how it's designed. But I can tell you, don't even think of all those things. It is not possible in India. So finally, medicine comes to business. And if it's going to be a government hospital, it is money. Finances don't really correlate. We don't have a single unified system. It won't work. Any other isolation zones? Anybody else? What does the word isolation means? Hmm? Cautious. Cautious. Isolation is separation, right? Any separate areas? Have you seen in the hospital? Has anybody been admitted in the hospital? Yes. Why were you admitted? Breathing. Did you see any room with a board in front? Contact isolation, respiratory isolation, something like that. No separate ward. Again, it's only a separate room. You were admitted for
appendicitis.
Appendicitis. Were you in the recovery area?
ICU.
You were in the ICU. So you must have seen some boards in separate rooms in that area. Those are isolation zones. Again, we don't have separate isolation hospitals. It is not possible. Even the TB hospital concept is leaving now. So what we do is taking all your helps and with some changes in HVAC system, the air ventilation system, we provide separate spaces to prevent contamination with others. So any infection which can spread from one person to another, those patients, especially by airborne route. Droplet means short distance, airborne is long distance. So those areas we make some changes and put them in that area. Again, hospitals do not have a lot of space. It limits the patient bone. Only difference between other areas and this is there's a separation and probably some changes in their HVAC system. If it's a contact isolation, it is generally a barrier, separate room. So these kind of isolation areas are to separate patients. What is quarantine? I talked about isolation. What is quarantine zones? Quarantine is it quarantine? Have you heard of the word quarantine in any other sense? Yes. So basically, quarantine is at this point of time you don't have the disease. You're worried that you have a disease and then you're separated. So any kind of epidemics coming in, some zone will be separated to quarantine zone. So here you can infection exposed people, some may have a mild infection and no infection. So isolation zones are patient a confirmed infection. Quarantine zones, there is a doubt they may develop the infection. We don't want it to spread from them to the community. Those are quarantine zones. So all the hospitals earmark a zone for quarantine, but it is usually with a normal patient. So for example, I work at Kaveri Vadapalli. So one particular wing in 9th floor is associated as identified as a quarantine zone. So if there is an outbreak, that area will be quarantined off. Now it's a normal ward. When you need, you have to change it. So for that, we need changes in the HVAC system, which is multi-purpose. It used to be negative pressure, positive pressure, now it should be interchangeable. Should be one row, now it has to become a zone. That is what the evolution is for. Finally, in any kind of cities, space is money. So each food, everything costs a lot of money. So how much ever you save, it's going to help you a lot. So then we talk about special zones. Special zones, dialysis. Do you require a hospital for dialysis? But it's in the hospitals. That's how India is. Slowly, a startup has come now. Dialysis things are going out. Still, they are struggling because corporates are fighting. Because when it goes out, they will lose their revenue. So, dialysis again, don't take about US and Western world, it is separate. So, it's called ambulatory dialysis. You go, get a dialysis, go back to your work. So, that's a separate unit and it's usually separated from the hospital for well people. But again, all these things have to come out. That's what you guys have to decide. So that will be a big change, and these will come out. I'm talking about daycare services. Dialysis will definitely come out because India is looking for cost-effective options. But neither the government is able to do it, nor the small-scale people are doing it. Somebody comes with a big bang, yes, but the profits and all these things are less compared to the hospital industry. That's why they're all not going up. But after some time, you won't have you really have on too many people, so innovations will come up. Next slide. Talking about IP investigations. So we're talking about open. Yeah. Yes. So we call it protective isolation. So when we talk about isolation, we have categories. One is contact isolation. That is by touching, if the infection can spread from one person to another, it's called contact isolation. What you need is a physical barrier. So a room separate, because we don't believe in your, if you have a curtain, the curtain can still spread. So it will be a separate room or a cubicle. That is for contact isolation. Next comes droplet isolation. Things like your flu. Uh, okay, some example for contact isolation can think touching and disease spreading. What you can think of? COVID is droplet.
Okay.
I'll explain it.
அவ்வளவுதான்.
Contact. TB is airborne. If you cough or sneeze and it spreads, then it is an air. Talking about touching and spreading. Simple things. Airborne. Simple things. What happens in your house when you get it, everybody gets it. You have, especially if one of you must be unmarried. Huh? Mite infections, that's like your scabies, then skin infections, skin infection, skin. Very good. Anything else? Think common things. Chicken pox is that. So you have skin scabs, droplets, and also diarrheas. All your diarrheas are contact point infection. Typhoid, hepatitis A, these are not spreading by touching. So in hospitals, there are some resistant bugs which can spread by touching. So we have then airborne droplet comes under respiratory secretions. If the it is going to spread within the short distance, we call air droplet. That's what is COVID. Airborne is it stays for a longer period of time. Classical example is chickenpox and TB, where it stays. If it's going to be this kind of, if I have TB, this kind of an environment, the TB organism stays like for a longer period of time. Spread is much higher. So then it's called airborne. So these are infection based. And we also use isolation for protection. So that's called protective isolation. One example is burns. A patient comes with burns, it's got a lot of exposed area. Why do we have skin on the surface? What does it do? How does it protect? And what does it protect against? How does it protect? Vital organ you have bone. Why when skin breach you say we're also worried? Blood, anyway, blood, most of the blood goes and oozes and what else does the skin do? pH balance comes, yes, skin has bits more underneath. Your electrolytes and the fluid inside the blood vessels and outside. The osmotic movements that are not maintain the pH and your urine going out. Simple things. Sunlight protection. Then, actually, no, we don't have much electric color resistance. That's why we get electrocuted very easily. Then, it protects against infections. It protects against trauma. It protects against any kind of physical barrier. Sunlight. So it also improvises your temperature, gives you hydration also. So when the skin is gone, you can get infections very easily. So when there is a lot of trauma, burns, we put a secondary solution. So as a healthcare worker, I should not give an infection to the patients. So I should do this protective isolation, which is the inverse of the time is also sir. It's the inverse of isolation which we talked about, where the patient is infected, you don't want the healthcare worker to get it and give it to others. Here, you are worried about you giving the infection to the patient. So one classic example is burns. Any other things where you require protective isolation? Very good. But not all chemotherapy patients require it. If they have chemotherapy, then no counts. That's called hallucinogenic isolation. And
சரியான
everything
வேலைங்க.
else.
போன் எழுதி
It's
போட்டாலே
very
எழுத
important.
மாட்டேங்குங்க.
In this era,
காலை
because
ஒண்ணுமே
we
எழுத
see a major particular transplants.
ப்ரொஜெக்ட
Early
போடாதாங்க.
post-transplant zone. Because designing early post-transplant equipments to prevent infection. All these are upcoming. So these group of people, what we do is protective isolation because we don't want them to get infection from you because they're so immunocompromised. What is sitting on your skin also can cause a pain. And remember, if I have 10 cells on my body, I have 100 bugs. I have 200 times more bugs on me than the number of cells. Is it difficult to take it? We are all organisms, viruses, bacteria, fungi. Everything is there on us. And we live with it. And we are alive because of
நாங்க
it.
2 பேரும் சொல்றதெல்லாம்
They protect us. Prevent infection. They help us.
அதுக்கு வேணாம். உங்கள்ட்ட
They give us
எல்லாம் வந்து புரிய வைக்கவே முடியாது.
Jesus.
யாரையுமே புரிய வைக்க முடியாது.
Right.
உங்கள மட்டும் இல்ல எல்லாருமே. எல்லாரையுமே நான் யாரை ப்ரிப்பேர் பண்ணி நீ பாத்துருக்கேன். இதோ 2 வருஷம் ஆச்சு.
In the hospital. If they don't have, they'll send it outside.
அப்படி இல்ல. 2 years ஆச்சு. இன்னும் satisfy ஆகல.
Things have changed. If I have a patient and let's say yesterday night, a patient came to the emergency. So night 10 o'clock, they call me, I say, this is in the patient. You know, usually we say ABG. Then my worry is whether the patient has got some is it chemet protocol. Chemet is a point of care test where I get an idea about electrolytes, creatinine, and hemoglobin. Within half an hour, I'll have an idea about these values. For me, if it goes to the lab for them to do and come, it takes around 2 hours. Now, within half an hour's time is collection, getting it, doing it, and then coming back and giving it. 10-15 minutes, I get the report. ABG 10-15 minutes, I get the report.
யார் சொன்னது? ஏன் இப்படி போட்டு டார்ச்சர் பண்றாங்க?
And make my plans. So, point of care test, which was initially devised for the peripheries, now are entering into the hospitals. It used to be why we used to assign point of care because you go to a village, you want to
எல்லாருக்கும் ஓடி கொடுத்து காலையில அனுப்பி விட்டுருவீங்க.
and that's why it was sold. Because obviously, who's going to pay for it? If it's going to be a PHC, government also doesn't have money. None of the corporates want to go to the periphery because of our payment issues. Now, point of care tests are coming everywhere. We use quite a bit of point of care tests in the hospitals per se. What I give you is a simple example. Similarly, portable machines. We used to have huge, bulky ultrasound machine transporting here and there. Now, when they have to go for a camp, let's say an antenatal surveillance camp, they take a small portable machine, which really makes it very easy. For example, we use ultrasound machine in the ICU for putting lines. We use it for simple things like a nerve block, that's decreasing your pain. All those things, it's a very small portable machine to attach with your cell phone, you read it, becomes extremely easy. So all these portable machines save space because space is money. It's portable, it's less cost, saves space, yes, the way to go. Then analytics. Now it used to be my test, I have to go back in the system and watch what happened in the previous test. My reports will now come. So Kaveri, we have something called as BI with artificial intelligence, BI combined together. So they will give a trend. So the lab technician will call up and say, Madam, நீங்க last time பண்ணும்போது PSA value 14 இருந்தது, இப்போ it is 3. Did you put on some treatment or what happened? That's what happens now. So I get analytics automatically when I get the test. And what I'm talking about is tertiary care hospitals. This has not penetrated much. Probably Apollos and Kaveris will have it. But this is the way to go. It makes life easier. And remember, this has to happen with a very low cost. Otherwise, with so much of people without job in our country, people are not going to buy. Next slide. And have you understood about all these things? Because the idea behind this session is for you to think about where all you can work. Any doubts till now? So let's talk about a patient admitted. What are the changes in treatment delivery? So if you talk about treatment, initially it used to be very simple. I give them medicines, they become all right, I send them home. I do a surgery, send them home. Interventions, maybe I do something like a pleural tapping, or take them for an angiogram, or do a dialysis and then send them home. Or they are in the ICU on a ventilator. So that used to be very simple before. Now we have added appendages. Critical care used to be simple ventilators and monitors, which have all evolved quite a bit. Now the concept of digital ICU has come up. That I'm not the expert in that. I'll just give you a preview about digital ICU, and rather I can tell you what we are doing so that you have ideas about it. So, for example, when there are ventilator, we get readings which can read on our cell phone, make decisions. Because mornings we have to decide few things. There are very few senior consultants. When we go in the morning rounds, I need to assess whether I can take him off the ventilator so that I need the previous 2 days effects. Everything comes digitally for me. Sometimes in the cell phone, sometimes in the monitor, but that gives me an idea. It is integrated. So that helps me a lot. And then distance monitoring. So we don't have nursing. Nursing problem is always there in all the hospitals across the world. There is no hospital which is immune to it. So if 1:1 nursing is something which we keep talking about, but nobody does. So what happens? You know there will be lapses. So you will have a monitor which gets all the tracking, and there is an alarm that helps you. Alarm at the table, now it's gone to alarm at a distance. It used to be ventilator beeping. But if the nurse shuts off and goes, nobody will be able to pick it up in middle of the night, 2 o'clock. When the doctors are asleep, the nurse won't have the mode to do it. Now everything is set and the doctor will get it. So that's the evolution which has happened in the critical care. Lot of things have happened in the critical care. I suggest you should have a session with them for that. That really helps them. Then talking about interventions. So I was talking about robotics. In surgery, robotics have made a lot of difference. Robotic surgeries are faster. A lot of surgeries, the efficacy and the precision seems to be much better. We're moving towards precision medicine, and for robotics, handling them along with analytics. I'm not even talking about AI because we haven't reached analytics in healthcare. None of us have an idea about, let's say, I handle 50 dengue patients, another person handles 30 dengue patients. I, in the same hospital, will not have an idea about what happened over the in this dengue season, what happened, what is the outcome. I would, because we all work in silos. In hospital setup, entire data doesn't come in, and then you can't even imagine what happens with other hospitals. It's not just in India. Take US too. They have separate insurance system. None of them interact. So each hospital data is with them, despite JCAs and other things. They don't share it. So nobody has become superior. Your UK used to try it out. Now they're very low on funds. Whatever interface they're putting, they're just not using it nowadays. They don't have manpower. So healthcare is in a dismal phase where India doesn't even know where we are heading. So analytics is extremely important. I'm not even talking about artificial intelligence because there's so much of changes. Before this, I was talking with Sir. We used to have funding from some trials, like giving 1 liter of IV fluids and 500 ml of IV fluids for a series of patients with bad infection. What's the outcome? This is not money because obviously none of the medicines are there in it. Then nobody is going to make money. But that really helps for a clinician to make a major decision. These kind of trials used to come funded by WHO-based groups or European groups. UK, US, sometimes CDC funds. All these funds have become dry because Europe is in dire financial crisis. After the new change in US, again all the funds are dried. And these kind of things, now the only way I can assess is probably through analytics and artificial intelligence. The next 10 or 15 years, we have to use them to know what changes happen, what has happened. Let me give a simple example. All of you must have heard about dengue fever. At least somebody in your family, somebody must have had it. So last 30 years, the management of dengue fever and the way the patients present has changed dramatically. If I teach it to my juniors also, nobody will know because it doesn't come in the textbook. So we used to have patients coming in shock requiring a large volume of fluid initially. So the guidelines of our National Vector Control Board, WHO, is based upon that. Let's say this was 30 years back. The requirement of fluid which the patient requires now is more than 50% less than that. The guidelines remain the same. How do I know? I manage frequently, every day, and I analyze my data. But how many of us do it? Remember, we are making robots from factories. That is how medicine is run now. We don't think, we don't analyze, we don't evaluate. I'm talking about medicine now. All doctors. So surgeons are skilled barbers. Medicine people follow the pathway. That's what we've all become. How will I know? How will I even know this has changed? Unless I analyze my data. That's where your things about big data analytics come in. If every hospital puts in, these things will automatically emerge. But the problem is nobody wants to spend. It is extra work. And none of us want to put the data in because we are also, as I said, most of us entered into medicine because maths is difficult or you don't want to work with the computers. So it is very difficult to make the doctor. So with these two ends, it doesn't happen. That is really not good for medicine because you will be killing some patients unknowingly, assuming you're doing right because you'll never know. Now the trials are also not going to come where they are going to get from your local data. We are at the stage where we don't know where we are heading. And I hope you all come into the picture to help us out. Right. Talk about robotics, automated clinical pathways, which gives us an idea about how to handle it. In the middle of the night, the junior doctor says a pathway comes and changes. They can easily see and take it. That's come up now. Alerts. All of us use alerts. I get an alert from my WhatsApp because none of us, if they say use an app and download it, we're all lazy people. Doctors absolutely lazy. We don't use it. We are not techno-savvy. So now our hospital is given in such a way alerts come through WhatsApp. WhatsApp is using my data, but what do I do? When JCA comes, I'll say we don't use WhatsApp. Otherwise, it's usually WhatsApp which we use. So alerts come through WhatsApp, so immediately I call them and say, give them instructions. Similarly, talking about interventions in cardio, gastro, Europe, phenomenal things have happened in these departments. So ID, nobody wants to put the money in because it's not a money-making field anyway. So it's considered an expense. But these are fields with interventions. Cardiology, now you have pacemakers, which have better automation. Pacemakers, you get evaluation analytics mode. Gastro, you have probes which go in and you just go to the entire gut and come out. With that, we know what is happening in the gut because we have something called as a large bubble. I should have asked for a board. Right, so all of us have something called esophagus and stomach. Below that, we have something called small bubble. It's huge loop. You don't have any way to go into it, and then the large bubble comes. In this small bubble, if there is a pathology, it is difficult to pick up. The only way you can pick up is through scans. So scans cannot pick up small things inside the lumen. So then we have some tablet which goes in, records everything, comes out, and then that is used to evaluate. It's called capsule endoscopy. Endoscopy goes in without somebody manually entering it. It's an innovation. It has made our life so much easier. So small bowel lymphomas, which used to be in the textbook, and we used to pick them at an advanced stage, every year I'm picking up one or two now. That's an innovation. Similarly, urology, scans, intraoral, you do a surgery, you do an endoscopic ultrasound, and then decide it is malignancy or not. Take a small cut, then you decide how much you cut. And then you use a robot to cut it more precision. So that's an innovation. So certain areas, the development has been amazing. I would say anyway there is an intervention, anyway there's a procedure, the innovations are amazing. Anyway, there's not much of a money, hardly anything comes and it degenerates. but everything has to go hand in hand. Next slide. So, device innovations. It's your field, but think about these 5 things when you are going to design something new. Any of these 5 things will work. Cost reduction. If you make a ventilator which is cheaper, people will buy it. Because we are worried about finances all the time. Be it Apollo or Kaveri or a small nursing home, everybody thinks money. No difference. Cost reduction helps. Automation helps because that decreases the stress on nurses. 10 years back, no, they assumed a nurse would write it down. Now they know getting a nurse to do a lot of work is going to have a negative impact on the patient outcomes, and patient probably want the nurse to talk to them and give them injection rather than write in a piece of paper. Automation helps if it saves time, if it is less price, if it improves the quality. Any of these 5 principles work on that. So even with existing machine, if you work with these 5 principles, there is a definitive difference. It will sell. And I'm not promising you, but yes, you should try. Next slide. So I'll stop here. I've just put in the basic concepts. I'm not sure, could have had it before too. Anything which you want to discuss at this point of time? We have half an hour more before delving into something which is happening here. Any questions? Any doubts? Yes.
When the first year is sitting, biomedical first year, so what kind of advice would you like? இப்போதான் ஃபர்ஸ்ட் என்டர் ஆயிட்டு ஸோ எப்படி நீங்க வந்து
நீ என்ட்ரன்ஸ் எக்ஸாம் எழுந்ததை மறந்து படிச்சதை மறந்து இதெல்லாம் தூக்கி போட்டு the rote memory, repeatedly doing things, throw it away. It's all making you dumb. Think, question. Have you heard of 5 whys principle? Huh? Why? Why am I doing it? Why is this? For a class at Tangana, you should have umpteen questions. The teachers should break their head. You should make us, you should entertain us. Ask. What is missing out with now is because of your stress towards your 12th exams and entrance, you're losing your originality. And remember, brain stops working after 30. I'm half demented, I'm 46. So this is a time for you to think, question, evaluate.